My name is Dr. Lynn Henry. I'm a breast medical oncologist at Huntsman Cancer Institute at the University of Utah in Salt Lake City. And I'm here today at the American College of Physicians, where I just spoke about current controversies in breast cancer with a specific focus on screening, on risk assessment, and on survivorship. So first, we talked a lot about how you actually assess your patient in terms of her risk of breast cancer and how it's important to obtain a really good family history, looking at 3 generations, so parents, siblings, and children, and focusing on both the maternal and paternal sides, because this is important both for figuring out what you're going to do in terms of offering chemoprevention strategies, offering genetic testing, and offering breast cancer screening. We talked about breast cancer screening quite a bit. This remains a very controversial area. As you may know, the American College of Physicians recently updated their guidelines this week. It's available for your review. And there continues to be some controversy about whether or not screening should start at age 40 or at age 50. Currently, the American College of Physicians is recommending starting at age 50, whereas other organizations continue to recommend starting at age 40 or 45, and especially using shared decision-making for women at earlier ages. In general, most organizations are recommending stopping at age 75, although that again depends on shared decision-making and on the comorbidities of your patient. So I encourage you to look at the new guidelines and make a decision for yourself about what you're going to offer for individual patients, because it certainly is not yet clear-cut. We talked a fair amount about genetic testing. This is a bit more straightforward, although much more complex than it used to be. We no longer just look at high-risk genes called BRCA1 and BRCA2, but instead there are a number of other both high-risk and moderate-risk genes that are being tested for. And so it's important to refer patients to genetic counselors or to high-risk clinics really for a discussion, because you want to make sure that you're ordering the right test for your patients and also testing the right person. In general, if there's a family member with cancer and your patient does not have cancer, it's the family member with cancer who's the one that you really should be testing. And so it's important to get a pedigree and take a careful look, and then consider referring, if possible, to genetic counseling, because they will know the intricacies of which test to order. They'll know a lot more about insurance issues, and they'll also be able to do pre-test counseling with your patient, because it's much more complicated than it used to be. You can get a positive result, which can be either high risk or moderate risk. It can be a negative result, or it can be something called a variant of uncertain significance, or VUS, which is that in-between gray area where you get a result back that shows that there's a change, but you really don't know if that change is related at all to the cancer. So, as I said, screening is important, and genetic counseling is important, and most important is for you to actually take a good family history beforehand so that you can best counsel your patients on both of those topics. And then finally, we talked about breast cancer survivorship with a particular focus on the sexual health of young breast cancer survivors. You know, we do a lot to our patients in terms of causing premature menopause, in terms of causing hot flashes, that all negatively impact their quality of life. For some of the things, we actually have good management options. So for example, for hot flashes, there are a number of drugs that are out there that can help decrease hot flashes without using hormones. Things like SSRIs, SNRIs, oxybutynin, gabapentin and pregabalin, and sometimes clonidine can all be effective. There also may be some non-therapeutic options such as acupuncture, hypnosis, and relaxation training. For vaginal dryness, it's much more complicated. We use moisturizers, we recommend lubricants, but sometimes people just have such severe vaginal atrophy that we have to think about using vaginal estrogen. When that's the case, we usually prefer inserts and rings over creams because it's a more defined dose. But we also have to take into account how the patient is doing, what her risk of breast cancer is, what type of breast cancer she had, and really have a good discussion with her about the potential risks and benefits. And then finally, we talked a little bit about pregnancy. There isn't a lot of data in terms of pregnancy following breast cancer and whether or not it's safe, but overall it does seem to be safe to get pregnant after breast cancer. There's an ongoing clinical trial trying to get more information about this, but meanwhile, the observational data we have suggests that it probably is safe if you wait a few years, get out of the high-risk period, and if your patient has estrogen receptor positive disease, to get a few years of anti-hormone therapy under her belt. So overall, we had discussions about risk assessment, about screening, about genetic testing, and about cancer survivorship, all related to breast cancer. Thank you very much.